All right, welcome back everyone to the deep dive. We talk a lot on this show about the latest advancements in medicine and emergency care, but today we're going even deeper. Deeper. We're going behind the scenes to understand how those guidelines for resuscitation, the ones that literally make the difference between life and death, are actually created.
Oh, I like where this is going.
We're talking about ILCOR, the International Liaison Committee on Resuscitation. They're the ones who comb through mountains of research to give medical professionals around the world the best possible advice on how to save lives.
Exactly. And that's what's so crucial for our listeners to understand about ILCOR. Their recommendations are rock solid because they're based on evidence, not opinions. It's not just a bunch of experts sitting around a table saying, well, I think we should do it this way. They have a really rigorous, systematic way of evaluating all the available scientific data.
And that system, that process, is what we're deep diving into today. Specifically, we're looking at how ILCOR is approaching their big 2025 update.
And there's one super important thing for everyone to know right off the bat. What we're discussing today is based on what's called a preprint of their consensus on science and treatment recommendations, their CoSTR for short.
Preprint. Okay, so like a draft version, not the final polished product.
Precisely. It's the version that's currently being reviewed by experts in the field. So while it gives us a fantastic sneak peek into what ILCR is thinking, some things could still change based on that feedback.
Got it. So we're getting an early look, but always keeping in mind that it's not set in stone just yet. That being said, how does ILCR even begin to tackle such a huge task? I mean, we're talking about reviewing research on literally every aspect of resuscitation.
It is a massive undertaking, for sure. To manage it all, ILCR primarily uses three main approaches. First, there are the systematic reviews, or SysRevs for short. These are really deep dives into very specific questions.
So if they want to know, say, whether giving epinephrine during CPR is better than not giving it, they do a SysRev on that.
Exactly. They scour the existing research to see what all the high-quality studies on that particular question have found.
Okay, that makes sense. And what about the scoping reviews? How do those differ from the SysRevs?
Think of scoping reviews, or scope revs, as more of a broad scan of the research landscape on a topic.
Okay, so if they're looking into, say, post-resuscitation care, they might do a scope rev to see what kind of research is already out there and what areas need more investigation.
You got it. And the third key approach is the evidence update, or EV-UP. This is where ILCOR regularly checks in on the latest research to see if any new findings have come out that might change their existing recommendations.
So it's like making sure the guidelines stay current with the newest science.
Exactly. The goal is to make sure they're always providing the best, most up-to-date advice possible.
Now, for this 2025 update, are they only looking at research that's been published in the last year?
Actually, no. Just like with their major 2020 update, this one takes a much broader view. It includes work from the past year, of course, but it also pulls in key findings from reviews they've conducted over the past 4 years.
So since 2020.
Exactly. They're looking at a 5-year span to get a really comprehensive picture of where the science stands today.
I can see why that's important. Things are always changing in medicine. Now, what happens when a research question spans across different areas of expertise, like something relevant to both adults and children, for instance?
That's where ILCOR's task forces come in. They have dedicated teams for areas like basic life support, pediatric life support, neonatal life support, and so on. And when there's a question that crosses over, they conduct what they call nodal reviews. So one task force takes the lead.
The one most relevant to the question.
Yeah, but they also bring in content experts from other task forces to make sure every angle is covered. And of course, they're incredibly strict about everyone disclosing any potential conflicts of interest.
Right, to make sure the recommendations are totally unbiased.
Yeah.
So let's talk a bit more about those systematic reviews, the SysRevs. They sound incredibly in-depth. What does that process actually look like?
It's very structured, which is how they keep things as unbiased and thorough as possible. The first step is to register their research question with something called Prospero.
Okay, Prospero. And what is that exactly?
Think of it as a kind of public registry for systematic reviews.
So it's all transparent. Everyone can see what questions they're investigating.
Exactly. And they register their question using the PI cost format.
PI.
Yeah, it stands for Population, Intervention, Comparator, Outcome, Study Design, and Time Frame. It's a way of defining the research question in a super specific way.
So there's no ambiguity about what they're actually looking at.
Precisely. They lay it all out right up front to ensure transparency and minimize the chance of bias creeping in later down the line.
Transparency and avoiding bias. Two absolute critical things when we're talking about saving lives. Okay, So they've registered their PI cost question with Prospero. What happens next in this SysRev process?
Next comes the really big task screening, literally tons of studies. I mean, when you're looking at all the research ever done on a topic, you can easily end up with thousands of articles to go through.
Wow, thousands. That sounds overwhelming.
It is. And they have to carefully examine each one to see if it actually addresses their very specific PI cost question.
So weeding out anything that's not relevant.
Exactly. And here's the key. This screening process is done by at least 2 independent reviewers.
2 separate people looking at every single article.
Yep. That way you have 2 sets of eyes making sure they're not missing any important studies and not including any that are off topic.
That's a really smart way to reduce errors and ensure consistency. Okay, so they've whittled down the pile to just the studies that fit their question. What then? How do they assess the quality of that research?
That's where the assessment of risk of bias comes in. They use specific tools to evaluate how well each study was designed and conducted.
So looking for any red flags that might make the results less reliable.
Exactly. For randomized controlled trials, they might use the Cochrane risk of bias tool. And for studies evaluating diagnostic tests, they might use QuADAS 2.
QuADAS 2?
Yeah. These tools help them assess things like how patients were selected for the study, whether the treatments were assigned randomly, and how the outcomes were measured.
So it's not just about what the study found, but also how much we can trust those findings.
Precisely. And the risk of bias is summarized for each study they include.
That makes a lot of sense. Okay, so they've got the right studies and they've assessed their quality. What's next in this evidence-gathering journey?
Once the risk of bias is assessed, they move on to data extraction. This is where teams of content experts carefully pull out all the key information from each study. They're looking at things like who the patients were, what interventions they received, and what the results were for important outcomes.
So they're creating a sort of summary of the relevant data from all the studies.
Exactly. And they put all this information into grade tables, which are like evidence profile table.
Grade tables.
Yeah, grade stands for grading of recommendations, assessment, development, and evaluation. It's basically a systematic approach to evaluating the certainty of the evidence for each outcome.
And how do these grade tables fit into the big picture?
Well, they use grade tables to summarize the findings from all the studies and make judgments about how certain they are about the evidence. They rate it as high, moderate, low, or very low certainty.
Oh, I see. So high certainty means they're really confident in the findings, and low certainty means there's more room for doubt.
You got it. And they use a software program called GradePro to help them create these tables, which are included in the published systematic reviews.
Okay, so it's a really standardized, transparent way of looking at the evidence. So how do they go from these grade tables to the actual recommendations that doctors and paramedics use in the field?
Based on the certainty of the evidence and whether the benefits of an intervention outweigh the harms, the task forces formulate their recommendations. They can be strong, weak, or even qualified, depending on the strength of the evidence and the specific situation.
Strong, weak, qualified. Okay, that makes sense. So a strong recommendation means they're pretty darn sure that this is the way to go, and a weak one means there's more uncertainty.
Exactly. And the qualified recommendations are kind of in between. They might say, in this particular situation, you should probably do this, but in another situation, it might not be the best approach.
So they're giving guidance, but also recognizing that there's not always a one-size-fits-all answer.
Precisely. And what's really interesting is what happens when there's not enough evidence to make even a weak recommendation.
What happens then? Do they just throw their hands up in the air?
No, not at all. They use what they call good practice statements. These are based on expert consensus and their understanding of the best approach, even if the hard scientific evidence isn't quite there yet.
So it's like saying, we can't give you a definitive do this or don't do that, but based on what we know, this seems like a reasonable way to go.
Exactly. It's providing guidance even when the evidence is still emerging.
That's good to know. So we've talked about the big comprehensive SysRevs. What about those evidence updates, the EV-ups? How do they fit into all of this?
The EV-up process is all about keeping the recommendations current. So every so often, ILCOR takes a look at the new research that's come out since the last review.
How often do they do that?
It depends on the topic. Some areas might get updated annually, others every 2 years, and some even less frequently.
So they're constantly monitoring the landscape to see if anything needs revisiting.
Exactly. And if they find new evidence that suggests an existing recommendation might need a change, they can raise a flag and say, hey, we need to take a closer look at this.
Okay, so the EV up can trigger a more in-depth review.
Exactly. It's a way of staying on top of the latest science. But it's important to note that they can't actually change a treatment recommendation based on an EV up alone.
They need to do a full sysrev to do that.
Exactly. And sometimes they might even decide to withdraw an older recommendation or downgrade it to a good practice statement if it doesn't meet their current standards.
So even those existing recommendations are constantly being reevaluated.
Absolutely. It's a continuous process of refinement and improvement.
Okay, that gives us a really good overview of how ILCR works its magic. Now let's get into the good stuff, the actual areas where they've reached a consensus on science and treatment recommendations based on this 2025 preprint. Given our audience, why don't we focus on the pediatric and neonatal life support updates, and then touch on any really interesting first aid findings.
Sounds like a plan. So, starting with the Pediatric Life Support Task Force, they tackled a whopping 39 questions for this update.
39. That's a lot of ground to cover.
It is. They look at everything from what to do before a child's heart stops to what happens during CPR to the care they receive afterwards.
So, pre-arrest, intra-arrest, and post-arrest.
Yeah.
Makes sense. What are some of the highlights from those 39 questions?
Well, one area where the science is still a bit murky is how to handle a child who comes in with a slow heart rate, or bradycardia, and poor perfusion, meaning their blood isn't circulating effectively.
So they're really sick, right from the start of CPR?
Exactly. The PLS task force looked at using atropine and epinephrine in these kids, specifically when the initial rhythm is bradycardia.
Atropine and epinephrine, those are both medications that can speed up the heart, right?
Exactly. The thing is, the evidence here is limited, and what we do have is a bit mixed. A 2020 study by Holmberg actually found that giving epinephrine in this specific situation might be associated with lower survival rates compared to not using it.
Wow, that's a bit counterintuitive, isn't it?
It is. But it's really important to remember that the certainty of this evidence is very low. We need more research to be sure.
So a grain of salt for now, but definitely something to keep an eye on. What about the rate of ventilation for kids who have a breathing tube, an advanced airway in place during CPR? Any updates there?
They reviewed this based on a 2024 SysRev and an EV up from this year, comparing different ventilation rates to the standard 8 to 10 breaths per minute for infants and children with an advanced airway during cardiac arrest.
So how many breaths per minute should we be giving?
Well, they haven't made any firm new recommendations yet, which probably means that the evidence didn't point conclusively to a specific rate being better than the standard 8 to 10 breaths per minute. More research is needed, as always.
Understood. What about the initial defibrillation dose for kids who are in those dangerous fast heart rhythms, ventricular fibrillation, or pulseless ventricular tachycardia?
They're sticking with the 2 to 4 joules per kilogram for the first shock, but, and this is important, it's still a weak recommendation based on very low-quality evidence.
So it's what we've been doing, but maybe not with as much confidence as we'd like.
Right, and what's even more interesting is that there's still not enough evidence to make a solid recommendation for the second and subsequent defibrillation doses in kids.
Wow, that's surprising. You'd think we'd have that figured out by now.
You'd think so, but it's a reminder that there's still a lot we don't know about how defibrillation works in smaller bodies.
Okay, so we've got the dose. What about where we place those defibrillator pads on a child's chest? Any changes there?
They've issued a good practice statement that says, if a CPR provider is trained to use a manual defibrillator, meaning they can adjust the settings, they should use an anterior-posterior pad placement for infants and children. So one pad on the front of the chest and one on the back.
Front and back instead of the usual side-to-side placement. Why the change?
It's based on the expert's understanding of the best way to deliver the electrical current through a child's body, even though we don't have tons of high-quality studies comparing different placements.
Okay, so it makes sense physiologically, even if the research isn't totally there yet. What about if a regular person, someone without medical training, needs to use an AED on a child? Any updates on that?
The PLS task force looked at this based on a SysRev from 2022 and a recent EV up, specifically for kids who have a non-traumatic cardiac arrest that happens outside of a hospital. And while we know that quick AED use by bystanders is super important for adults, the evidence in kids is still a bit hazy. It seems like it could be beneficial, but more research is needed to be sure.
That makes sense. Kids aren't just little adults. Their hearts are different. Speaking of differences, let's talk about something that seems so basic, checking for a pulse in a child during CPR. How reliable is that, according to the 2025 update?
You're going to love this. The 2025 SysRev on the accuracy of pulse checks in kids found a huge amount of variation. Some studies said they were pretty good at detecting a pulse when one was there, but others said they weren't that accurate at all.
And are we talking about feeling for a pulse at the wrist, the neck, the groin?
That's the other interesting thing. The studies they looked at didn't really compare different locations for checking a pulse. So we're still not totally sure where's the best place to check or how much we can rely on that feeling alone.
So even that seemingly simple skill has some nuances that we need to understand better. What about using blood pressure as a guide during CPR in kids?
They specifically looked at the diastolic blood pressure, the bottom number, and whether keeping it above a certain level during CPR is beneficial.
And what did they find?
The evidence is still super weak, but there are 2 observational studies that suggest that keeping the diastolic blood pressure above 25 for infants under 1 year old and above 30 for children 1 and older during the first 10 minutes of CPR might be associated with better outcomes.
Okay, so a possible link, but more research is definitely needed to confirm it. What about medications like epinephrine during CPR in kids? Any new insights there?
Their 2025 review on using vasopressors, which includes epinephrine, in kids basically reinforces that the evidence is still pretty shaky.
Shaky how?
Well, they have conflicting results about whether it actually improves survival and long-term brain function.
So we're still not sure if it makes a real difference in the long run.
Right. But the review did find that giving epinephrine seems to increase the chances of getting a heartbeat back, what they call return of spontaneous circulation, or ROSC.
So it might help in the short term, but the long-term benefits are still up in the air.
Exactly. And what about when to give that first dose of epinephrine? Remember the give it ASAP mantra?
Oh yeah, give it as early as possible.
The 2020 recommendation to give it early in kids with a non-shockable rhythm is still in place, but it remains a weak recommendation based on very low certainty evidence.
So still early, but maybe not with the same urgency as before.
Right. And the 2025 EV-UP looked at new observational studies, but none of them really gave any clear guidance on specific time intervals for giving that first dose. More research is needed, surprise, surprise.
Always more research. Makes sense. Now, shifting gears a bit, did the review look at whether things like a child being overweight might affect their chances of surviving a cardiac arrest?
It did touch on that. There's one study, just one, that found that obese kids were less likely to survive to hospital discharge and less likely to achieve a ROSC after cardiac arrest compared to kids who were at a healthy weight.
So it suggests that a child's weight could be a factor, but we need way more data to confirm that?
Sure.
What about using calcium during CPR in kids? Is that still a thing?
The CISREV from 2023 and the EV-UP from this year both looked at that, and they found an interesting tidbit. An observational study suggested that kids with underlying heart problems who got calcium during an in-hospital cardiac arrest actually had worse survival.
Oh, wow. That's the opposite of what you'd expect.
Right. It reinforces the idea that we should really only be using calcium in very specific situations, like if someone has extremely high potassium levels or extremely low calcium levels.
Not just throwing it in there for the heck of it.
Yeah.
Good to know. Now, let's get into a really complex scenario. What about babies born with single ventricle physiology where they only have one pumping chamber in their heart and they have a cardiac arrest? Any guidance on using eCPR in those cases? Yeah, extracorporeal cardiopulmonary resuscitation. It's basically like a heart-lung bypass machine.
Oh, right. Well, the CISREF that looked at data up to October 2023 found very low certainty evidence from observational studies on eCPR in kids with single ventricle physiology.
So not a lot to go on.
Not really.
Yeah.
And there were no studies that directly compared eCPR to standard CPR in this specific group. So while some studies hinted that eCPR might be better, we really need more robust data to be sure.
It's such a specialized area, I imagine it's tough to do large-scale studies.
Okay.
Okay, last one in the pediatrics realm. What about predicting how well a child will recover neurologically after a cardiac arrest? That must be so hard for both families and the medical team.
Incredibly hard. The key is to try and figure out which kids are unlikely to have a good neurological recovery, but also being super careful not to be overly pessimistic. You don't want to withdraw care from a child who might still have a chance.
So how are they approaching this prediction?
The 2025 update looked at both using the clinical exam things like checking their pupils and their level of consciousness and using electrophysiology tests like EEGs, which measure brain activity.
So looking at both the physical signs and what's happening in the brain itself.
Exactly. And what they found for the clinical exam was, drumroll please, very low certainty of evidence for how well it can predict outcomes on its own.
So no single thing you see when you examine a child is a perfect predictor.
Not really. They emphasize the need to do more research on how well these assessments work together, what they call a multimodal approach.
Makes sense. What about the EEGs? Do they give more reliable information?
The review on EEGs in kids found some promising signs. Certain EEG patterns and the presence of continuous seizures seem to be associated with worse outcomes. But again, the evidence is still pretty shaky, mostly low to very low certainty.
So a potential tool, but we need to refine it further. Okay, let's move on to those tiny humans, the newborns. What are some of the key takeaways from the Neonatal Life Support Task Force?
They've been busy refining the neonatal resuscitation algorithm. One new addition is a good practice statement that recommends having a team briefing before a delivery when they expect that the baby might need resuscitation.
So getting everyone on the same page before things get hectic.
Exactly. This includes communicating with the obstetrics team, the folks taking care of the mom, so everyone knows the plan.
What about managing the umbilical cord after birth? That's been a hot topic lately.
There's a new SysRev on this, specifically for babies born full term or close to it who aren't doing so well right after birth. And the evidence continues to support either waiting to clamp the cord or using umbilical cord milking instead of clamping it right away.
And is that for all babies or just the ones who aren't vigorous?
For healthy babies born at or near term who are breathing and moving well, the recommendation from previous reviews to wait at least 60 seconds before clamping is still in place. And importantly, there's no new evidence of any harm from waiting.
So, delayed cord clamping is looking pretty good. What about keeping those little ones warm after they're born? Any new wisdom on temperature management?
The recommendations for skin-to-skin contact for term and late preterm infants are still weak, based on very low certainty evidence. And if skin-to-skin isn't possible right away, they suggest considering things like plastic bags or wraps to help prevent the baby from getting cold, along with other measures.
Okay, so keeping them warm is important, but how we do it best is still somewhat unclear. What about when a baby is born through meconium-stained amniotic fluid? Is that still a big concern?
The recommendation against routinely suctioning the baby's trachea right after birth in this situation is still in place. It's a weak recommendation based on low certainty evidence, but it reflects a shift away from that intervention.
So less is more in this case.
Pretty much. The focus is on providing supportive care and only intervening if the baby is clearly struggling.
Makes sense. What about using CPAP, continuous positive airway pressure, for premature babies who are having trouble breathing?
They looked at this again, but the evidence still isn't strong enough to say for sure whether routinely using CPAP is beneficial or not.
So another area where more research is needed.
Absolutely. It's tough to do those studies in such fragile babies, but it's crucial to get those answers.
What about those first breaths we give to a newborn, sometimes called sustained inflations?
They looked at this again too, and unfortunately, the certainty of the evidence is still very low. No changes there.
Okay. What about supraglottic airway devices? We're seeing those used more and more in adults, but what about in newborns?
It's interesting. There aren't any human studies in the delivery room setting, but there are studies in newborn piglets that suggest supraglottic airways might be just as good as endotracheal tubes during chest compressions. However, a SysRev from 2022 concluded that we just don't have enough evidence to make a recommendation either way.
So, promising, but more research is needed. What about videolaryngoscopy for intubating newborns? Is that becoming the standard?
They have a weak recommendation, again based on very low certainty evidence, to suggest using videolaryngoscopy, but only if the resources and training are available. It seems to be most helpful for less experienced providers, but the cost and potential equity issues are concerns.
That makes sense. What about that very first breath we give to a newborn? Specifically, what concentration of oxygen should we use?
This is a big one. ILCR has actually withdrawn their previous strong recommendation against starting resuscitation with 100% oxygen in full-term and late preterm infants.
Wow, that's a major shift. Why the change?
They basically said they weren't as confident in the evidence behind that previous recommendation as they'd like to be. So while they're not necessarily saying to use 100% oxygen now, they're acknowledging that we need more research to be sure.
So a big question mark for now, but hopefully more research will shed some light. Okay, back to basics. When should we start chest compressions in a newborn?
Good practice statement says to start compressions if the heart rate is less than 60 beats per minute, and that's after making sure they're getting good ventilation.
What about the ratio of compressions to breaths? Still 3-to-1?
Yep, the 3.1 ratio for newborns is still the weak recommendation, with very low certainty evidence. And they also say to not rely solely on things like end-tidal CO2 or pulse oximetry to tell if the baby has ROSC. They're helpful, but not the be-all and end-all.
Always good to have multiple ways of assessing. What about the mechanics of chest compressions in newborns? Any changes there?
They recommend compressing the chest to 1/3 of its depth from front to back. And for hand placement, the two-thumb encircling technique is still the preferred method, although the evidence is still very weak.
Okay, 2 thumbs it is, if possible. What about medications during newborn CPR, specifically epinephrine?
Weak recommendations suggest giving epinephrine if the heart rate stays below 60 despite ventilation and compressions. They say to go with IV or IO if you can, rather than giving it through the breathing tube, and repeat doses every 3 to 5 minutes if needed.
What about managing the baby's blood sugar during resuscitation?
This is interesting. They basically said there's no good human data on how to best manage glucose levels during resuscitation itself. More research is needed.
Wow, I wouldn't have expected that. What about how long to continue resuscitation efforts in a newborn?
The message here is that while a baby who hasn't achieved ROSC after 10 to 20 minutes of good resuscitation has a low chance of a good outcome, there's no specific time that definitively predicts whether they'll survive or have good neurological function in the long run. It's a complex decision that needs to be made on a case-by-case basis.
That makes sense. It's not a one-size-fits-all situation. And lastly, for newborns, what about family presence during resuscitation?
There's a weak recommendation that it might be reasonable to allow parents to be present as long as they have adequate support. It acknowledges the potential benefits for the family while also recognizing that it needs to be done carefully and sensitively.
That's a tough one, but I'm glad they're addressing it. Okay, let's jump to first aid. I know the task force always has some interesting findings.
Right. They use the same PI/SOCOS format for their reviews, but they also take into account things like whether a layperson has a duty to respond, how invasive a treatment is, and the setting where the first aid is being given.
So they're really considering the unique context of first aid.
Absolutely. And one interesting update is a good practice statement about giving oxygen in first aid settings. For people who are having sudden breathing difficulty and have COPD, they suggest using a pulse oximeter to titrate the oxygen and aim for a saturation between 88 and 92%.
So even in first aid, we're moving toward more precise oxygen administration. What about first aid for someone who's just started to become unresponsive?
The First Aid and BLS task forces actually teamed up for a SysRev on that, focusing on non-traumatic causes of reduced responsiveness that don't require immediate CPR.
So recognizing those early signs and responding appropriately.
Exactly. Early intervention is key. They also looked at how well first aid providers can recognize the signs of anaphylaxis, a severe allergic reaction. Quick recognition is vital so someone can get epinephrine if needed.
Absolutely. What about more common first aid scenarios, like someone having chest pain? Any new advice on giving aspirin early?
There's a weak recommendation for first aid providers to give aspirin to adults with non-traumatic chest pain compared to waiting until they get to the hospital. So early aspirin might be beneficial, even if given by a bystander.
What about helping someone with low blood sugar?
Strong recommendation for giving glucose tablets to conscious adults and children with hypoglycemia, and a weaker recommendation for using other dietary sugars if tablets aren't available.
Makes sense. What about recognizing a stroke in a first aid setting?
They looked at that too. It's all about being familiar with the FAST acronym and being able to quickly call for help if you see those signs.
What about first aid for a woman who's having heavy bleeding after giving birth? Can a bystander do anything helpful?
A 2024 SCOPREV looked at that. They considered things like giving medications by mouth, rectally, or intramuscularly, which might be feasible in a first aid setting, as well as uterine massage. They noted that we need more research on lay provider uterine massage specifically.
So, potentially life-saving interventions that we need to explore further. What about using naloxone for suspected opioid overdoses?
They have a good practice statement recommending that lay providers who are trained in naloxone administration should consider giving it in these situations. It highlights how crucial it is to empower bystanders to help in these emergencies.
Absolutely. What about something seemingly less serious, like someone feeling faint?
There's a weak recommendation for using physical counterpressure maneuvers for people who are feeling faint from vasovagal or orthostatic causes. Things like crossing your legs tightly or squeezing your fists can sometimes help.
Simple, but potentially effective. Now, what about the risk of accidentally hurting someone by doing CPR if they're not actually in cardiac arrest?
The 2025 SysRev looked at this, and while the evidence is weak, they basically concluded that the benefits of bystander CPR far outweigh the risks. We need to keep encouraging people to act if they think someone needs help.
It's better to err on the side of action. What about spinal motion restriction in first aid?
Interestingly, there wasn't enough evidence to support a good practice statement on this. They're planning more focused sysrebs on this topic in the future.
So, another area where our traditional thinking is being challenged, what about managing bleeding? Any updates on tourniquet use?
They still strongly recommend tourniquets for severe limb bleeding, and they have a good practice statement for infants and children saying to use direct pressure with or without a hemostatic dressing, since their limbs might be too small for a tourniquet.
Makes sense. What about hemostatic dressings themselves? Are they becoming the standard?
The evidence is still mostly from military trauma scenarios. They can be helpful, but more research is needed to see how well they work in other settings.
What if someone has an amputated body part? What's the best way to handle that?
Retrieve it and bring it to the hospital. And if there's delay, rinse it with clean water, wrap it in a moist dressing, seal it in a bag, and place the bag on ice, making sure the part doesn't directly touch the ice.
Specific instructions, good to know. What about good old-fashioned tick bites?
Use fine-tipped tweezers to remove the tick. Nice.